Today we'll discuss about the diseases in the pulp and the periradicular tissues. If you observe the dental pulp, it is a vascular connective tissue contained within the rigid dentinal walls. So here it is the principal source of the pain in the oral cavity, and some of the important features of the pulp includes that it is a coherent soft tissue surrounded by the dentin and has a limited area for expansion. And the odontoblasts present in the pulp have the ability to form the dentin in response to the caries and also the other irritants. And also it is lacking the collateral circulation, which limits its ability to cope up with bacteria and the necrotic tissue. And it gives the radiographic appearance as a radiolucent line. If you see the etiology of the pulpal diseases, it includes the physical changes, such as it may be due to the mechanical or the pathological wear, such as an attrition or an abrasion. If you see the thermal changes, it may occur due to the heat generated by the cutting instruments. And if you see the chemical changes, it may be occurring due to the erosion, that is, the acids released from the soft drinks, and also due to the regurgitation. And the bacterial cause is one of the major cause of the pulpal injury by their byproducts. It may be due to the caries or by the accidental exposure or percolation around the restoration. And the idiopathic causes, such as an resorption, it may be the either internal or the externals, and also the aging is one of the cause of the pulpal diseases. If we observe the progression of the pulpal pathology, it may be occurring due to the irritation in the pulp, that is by the caries in the coronal pulp tissue, results in the local disturbances. But if the injury is severe, it will result in the complete stasis of the blood vessels in and near the injured tissue. That's how the pulpal pathologies occur. And the spread from the maxillary teeth may cause a purulent sinusitis, meningitis, and the brain abscess, and also leads to the cavernous sinus thrombosis. Whereas spread from the mandibular teeth may cause the Ludwig's angina, parapharyngeal abscess, mediastinitis, pericarditis, and empyema. So these are the pulpal inflammation with its sequelae in and around the oral tissues. If you see the classification of the pulpal diseases, according to the Grossman, it is the pulpitis, which is the inflammatory disease of the dental pulp. It is further classified into the reversible pulpitis, which may be the symptomatic or acute, or the asymptomatic or chronic. And also the irreversible pulpitis, which is also the acute, or that is, if you see, it is abnormally responsive to the cold and also abnormally responsive to the heat in case of the acute irreversible. And the another type is the chronic, which is asymptomatic in its nature with the pulp exposure. And others, such as the hyperplastic pulpitis and also the internal resorption. If you see the pulp degeneration, in that we have the calcific degeneration, which is diagnosed by the radiograph, and the others, such as the atrophic degeneration, which is diagnosed through the histopathological changes. The other one is the fibrous degeneration. So next would be the pulpal necrosis. These are also the sequelae of the pulpal diseases. We'll see about the pulpal conditions such as the barodontologia, that is also known as aerodontalgia. It is the pain experienced in a recently restored teeth during the low atmospheric pressure, that is an altitude over 5,000 feet and or above. So That's how this parodontology occurs. Now we'll see about the reversible pulpitis. It is a mild to moderate inflammatory condition of the pulp caused by the noxious stimuli in which the pulp is capable of returning to the normal state following the removal of the stimuli. So, in this, the pain is localized with the cold stimulus. So, the treatment option for this is the prevention. Usually, sedative dressing is placed, followed by the permanent restoration when the symptoms completely subside. So, next we'll see about the irreversible pulpitis. If you see the irreversible pulpitis, it is a persistent inflammatory condition of the pulp which is caused by the noxious stimuli. And it is an intense, continuous, prolonged pain due to the pressure of the secondary irritants. In this, the pain is localized through the heat stimuli. If you see the treatment options, one of the treatment option is the pulpectomy for the single roots, and for the multiple roots we can go for the pulpotomy and also with an occlusal adjustment. Next, we'll see about the chronic hyperplastic pulpitis. It is a slow and progressive carious exposure of the pulp, and it is an inflammatory response of the pulpal connective tissue due to the extensive carious exposure of the young pulp. So, if you see in this, it is usually asymptomatic, but a fleshy pulpal tissue fills the pulp chamber, which is less sensitive than the normal pulp. But it bleeds easily due to the rich blood supply. And the treatment would be the complete removal of the polypoid tissue with a spoon excavator, followed by the root canal treatment. Next, we'll discuss about the internal resorption. It is initiated in the pulp cavity, which occurred by the loss of substance from the dentinal tissue. And it is a progressive resorption occurring in the dentin of the pulp chamber. If you observe the mechanism of the resorption, here the pulpal inflammation due to the infection occurs, which will lead to the alteration or the loss of predentin and the odontoblastic layer. So these undifferentiated mesenchymal cells will come in contact with the mineralized tissue. So these cells will again differentiate into the dentinoclast. That's how the resorption occurs. So this is the mechanism of the internal resorption. So the treatment option for this is the pulp extirpation, which will stop the internal root resorption. And also the surgical treatment is indicated if the conventional treatment fails. Next, we'll see about the pulp necrosis. If you see the pulp necrosis, it is the death of the pulpal tissues. So it's a noxious insult and the injuries to the pulp by the bacteria, trauma, and the chemical irritation. And it is of two types. One is the coagulation necrosis, that is the protoplasm of all the cells becomes fixed and opaque here, which is recognizable by histologically only. And the liquefactive necrosis is that the entire cell's outline is lost, and liquefied area is surrounded by the dense zone of the PMNL cells and the inflammatory cells. So the treatment option would be the complete removal of the pulp, followed by the restoration or the extraction of the non-restorable teeth. Now we'll see about the pulp degeneration. The pulp degeneration is usually present in the old age, and whereas in younger age it may result from the persistent mild irritation. If you see in the pulp degeneration, here the number of collagen fibers or the unit area increases, leading to the fibrosis. And also the number and the size of the cell decreases. And the cells appear here as a shrunken solid particles in a sea of dense fibrosis. That's how the pulpal degeneration is characterized. Now we'll see about the calcifications which play an important role during the root canal preparation. So these are the deposition of the calcium salts in the dead or the degenerated tissues. And these are of three types. That is the free pulp stones which are found in the pulpal tissue, whereas embedded pulp stones which are embedded in the dentin, whereas attached pulp stones which are attached to the wall of the pulp tissue. That's how the pulp stones are characterized, and the treatment option would be the use of the lubricants and also the removal of the pulp tissue from the tooth. Now we'll see about the periapical pathologies. Here the microorganisms into the pulp from the periodontal pocket and the axillary canals, resulting in the formation of the lesion of the endodontic origin. That's how the periapical lesions occur. If you see the Grossman's classification, the symptomatic peri-radicular diseases are symptomatic apical periodontitis. It may be vital or the non-vital, and the acute alveolar abscess and the phoenix abscess. Now we'll see the asymptomatic peri-radicular diseases, which are asymptomatic apical periodontitis, also known as the chronic apical periodontitis, and the chronic alveolar abscess, radicular cyst, and the condensing osteitis, and the external root resorption with the persistent apical periodontitis, and also the diseases of the peri-radicular tissues of the non-endodontic origin are under the peri-radicular pathologies. Now we'll see about the acute apical periodontitis. It is a painful inflammation of the periodontium as a result of trauma, irritation, or infection through the root canal, regardless of whether the pulp is vital or the non-vital. So, here in acute apical periodontitis, here it is tended to the percussion. That's what we can see in it. If you observe the vital pulp which has been infected and which is causing the apical periodontitis, in such conditions the treatment option would be the mechanical instrumentation and irrigation with a dressing. Later on it is filled and later on it is healed, and after few months we can see the complete healing. That's how the apical periodontitis is treated. Now we'll see the acute apical abscess. It is an inflammatory reaction to the pulpal infection and the necrosis, which is characterized by the rapid onset, pus formation, spontaneous pain, tender on percussion, and eventual swelling of the associated tissues. So if you observe the pathophysiology of this, if suppose there is an increase in the pulpal pressure, which will lead to the collapse of the venous circulation, which again leads to the hypoxia and anoxia of the local tissues, which further causes localized destruction of the pulp tissue and the formation of the pulpal abscess, which will break down the PMNS cells, bacteria, and the lysis of the pulpal remnants. That's how the pathophysiology of the acute apical abscess occurs. And if you observe the management of this acute apical abscess, it is the drainage of the abscess which should be initiated as early as possible. And next we'll see about the phoenix abscess. It is defined as an acute inflammatory reaction superimposed on an existing asymptomatic apical periodontitis. So, establishment of the drainage and after the symptoms subside, the complete root canal treatment would be an treatment option for this. The periapical granuloma, it is the mass of the chronic inflamed pulp, inflamed granulation tissue found at the apex of the non-vital teeth. If you observe the treatment option for this, it is in the restorable teeth, the root canal therapy is preferred, whereas in the non-restorable teeth, extraction followed by the curettage and of the apical soft tissue is recommended. If you observe the radicular cyst, it is an inflammatory cyst which results because of the extension of the infection from the pulp into the surrounding apical tissues. So, if you observe here, it says that the periapical inflammatory changes causes the epithelium to proliferate and make the center mass deprived of the nutrients from the peripheral tissues, which results in the necrotic changes in the center, which are lined by the epithelial cells at the periphery. That's how this center tissue is devoid of the nutrition and will cause an abscess. And if you see what is a base cyst it is a periapical pocket where proliferation occurs with the body of the granuloma, and it plugs apical foramen which will limit the egress of the bacteria. So sometimes the epithelial plugs protrude out from the apical foramen, resulting in the pouch connected to the root, and it is continuous with the root canal. So that's how it is termed as a pocket or the base cyst. So the treatment option for the radicular or the residual cyst is that the endodontic treatment or the episectomy, and in severe bone loss cases, we often go for the extraction. So this is brief about the pathologies of the pulp and the periapex.